Good evening, my esteemed professors and dear colleagues. Bardo? Good evening. Good evening, my esteemed professors and dear colleagues. We'll be launching, inshallah, by God's will, the immunology, pulmonology cross talks by an interesting case. We have a written consent from the guardians to share the full medical data of the patient. Our patient is a 13-year-old male patient named Muhammad Mustafa Abdel Fattah. He was born and living in Fayoum to a consanguineous marriage. His main complaint is recurrent attacks of fever and breathlessness. In his early infancy and early childhood, he was diagnosed with a mild asthma that would recur every 2 to 3 months and last for 3 to 4 days, and was improved by at-home nebulizations of beta-2 agonists. He was not on any prophylactic medication, and he was asymptomatic in between attacks. And he was never hospitalized until the age of 10. In September of 22, he had high-grade fever and dyspnea. He went to Fayoum Insurance Hospital and did a nasal swab and was positive for COVID-19. He was admitted for 5 days and discharged on home oral antibiotics and nebulizations, but the symptoms lingered for 3 more weeks. He was okay for 6 months after that, and then he again had a high-grade fever and dyspnea. He went to Fayoum Fever Hospital, was diagnosed with pneumonia, admitted for a week, and discharged with some symptoms to continue oral medication at home. However, his symptoms worsened, and he was referred to Abu Rish. He was admitted in March of 2023. In Abu Rish, he did several investigations, lab and radiological, and received a certain diagnosis. He received intravenous pulsed steroids for 5 days, followed by a full dose oral steroids. He improved and was discharged and was following up in the pulmonology clinic. And for the next year, he did not need any admissions. However, in 2024, he was admitted 6 times for 6 different attacks of pneumonia. And in most of those, he needed pulsed steroids. In 2 of the admissions, he needed PQ, one of them for 18 days, and developed a severe oral thrush and received voriconazole for it. To sum up, he had 10 admissions over less than 3 years, 7 of them over the last 13 months only. This rapid rate of repeated pneumonias led us to consult the immunology department, and he did several investigations. However, it is worth noting that he had no other significant infections, no GI symptoms, no sinusitis, otitis media, or abscesses. The child is now on continuous medication with prednisolone, sildenafil, amlodipine, nebulized budesonide, septazole, itraconazole, and pantoprazole. He is following up in the pulmonology, immunology, cardiology, and endocrinology departments. His past history: Muhammad was born at full term by normal vaginal delivery. His mother gives a history that he developed a fever at age of 1 week, moderate grade. He went to a private doctor who prescribed oral antibiotics and was not admitted to NICU, and it resolved. Other past history elements are acceptable. In the past history, other than the mild bronchial asthma we already mentioned, the mother states that he developed during summertime, some facial pustules that would drain spontaneously, and sometimes were associated with lymphadenopathy that would resolve after drainage of the pustules. No history of surgeries or blood transfusion. His family history: he's the first sibling of a consanguineous marriage. His 2 younger sisters are normal, and no similar conditions in the extended family. Environmentally, no passive smoking, no exposure to poultry or animals, and no nearby polluting factories. Examination at the time of discharge, the last discharge last March, he was conscious, oriented, cooperative. His vital signs were stable, blood pressure controlled by amlodipine. His oxygen saturation was 92 in ambient air. However, his measurements were both below the 3rd percentile. The Z-score for height was -3.7 and for weight -3. He has Cushingoid facies, however, no cyanosis nor lymphadenopathy. His limbs showed grade 2 clubbing in fingers and toes. Just examination. Inspection, palpation, and percussion were within normal. Auscultation demonstrated slightly diminished air entry bilaterally and no adventitious sounds on this, at time of discharge. Other system examination was acceptable, no organomegaly, no generalized lymphadenopathy. Lab investigations, as you can see, we chose a few samples from his labs. The CBC showed a normal hemoglobin in most admissions. Once he had just a mild iron deficiency anemia that was corrected by iron therapy. His TLC was either normal or showed a mild leukocytosis with no bandemia or shift to the left. However, his CRP was always high at time of admission, but by the time of discharge, it usually normalized or was near normal. His chemistry, all his chemistry was normal except for a random blood sugar once at the time of the last admission was 166 from the stress and the prolonged steroid usage, but by the time of discharge, it came down to normal. That's the rest of his chemistry, all normal. Microbiological examination, as we mentioned, he did a nasal swab for COVID in 22 and it was positive. Some bacterial cultures showed once strep pneumonia and once Moraxella catarrhalis. He did bronchoscopy last November and bronchoalveolar lavage was cultured. The fungal culture grew Aspergillus. He was tested for TB by Zeal Nielsen and Gene Expert, both turned out negative. The bacterial cultures, all the plates showed fungal growth, so we could not assess for bacterial growth at that time. Immunological tests will be revealed very soon, so stay tuned. Radiology. In this X-ray, you can see there is a left upper lobe consolidation and some hyperinflation. The CT, if you can see, there is a ground glass attenuation, generalized, both upper and lower lobes, right and left, as well as reticular attenuation, which led us to a diagnosis of interstitial lung disease. There is as well bilateral patchy consolidations of pneumonia. These are summaries of some of his radiological examination. As you can see, consolidation was documented in several of his admissions. Sometimes it was left upper, once it was right lower, and twice it was bilateral and patchy. In addition of the CT showing the ground glass and interstitial thickening, the changes that led to the diagnosis of interstitial lung disease. Echocardiography was done, and he had some pulmonary hypertension that was mild initially, but as the disease progressed, it became more moderate to severe, and sildenafil was started. Abdominal ultrasound was within normal. There was no organomegaly or intra-abdominal lymphadenopathy. DEXA scan showed a low bone mineral density done upon advice from the endocrinology department to monitor steroid side effects. Pulmonary function tests, as you can see, this teeny tiny flow volume loop is consistent with a restrictive pattern, and the expiratory portion of the loop shows some scooping consistent with an obstructive pattern as well. If you look at the numbers, you'll find that all parameters are way below the 80% benchmark, which is consistent with a combined obstructive and restrictive change, and there was no improvement post-bronchodilator, so no reversibility. As we mentioned, bronchoscopy was done last November. It showed normal anatomy, heavy white mucopurulent secretions. Bronchoalveolar lavage was taken from the right middle lobe and the lingula, and we mentioned already the microbiological results. This, I can play a small portion of the bronchoscopy. Okay. I'm trying to choose a clip because we don't have time to see the whole video. These are the vocal cords. This is the trachea. As you can see on the left side, the white mucopurulent discharge. And as we approach the carina, the discharge increases. We'll proceed because of time restrictions. To sum up the case in one slide, so up till the age of 10, in the year 2022, he only had mild asthma with no admissions whatsoever. In the year of 2022, he had one admission for COVID-19. In 2023, he had 2 admissions for the same attack of pneumonia. And when he came to Abu Rish, he had his diagnosis of interstitial lung disease. However, in 2024, he had 6 different admissions for different attacks of pneumonia. Immunology was consulted, and he received a diagnosis of a certain primary immunodeficiency. And in 2025, he had 1 more admission last month. Revealing the big surprise, his immunoglobulins were normal. However, his DHR stimulation index was 44, while the normal is above 70, and the control done on the same day was 717. His NAD pH protein components showed a deficient protein 47 FOX. So our child has the diagnosis of interstitial lung disease, chronic granulomatous disease, complicated by core pulmonale. For the crosstalks, I'll end my speech with a few questions to my next speakers. To Professor Dr. Azza, I'd like to ask, what is the proper approach to a case of interstitial lung disease, and is it a common association with CGD? To Dr. Dina, is this pattern of infection common in CGD, to have only pneumonias and these microorganisms? And to dear Dr. Mag, why did CGD not symptomatize before the age of 10 years before he had COVID? Thank you.